This test is not going to be as hard as I think you think it's going to be. That's the hope and dream. All right, so starting from the top, hypomagnesia. Throwing that out there. Have maybe an idea of what that does to the heart in terms of conductivity, contractility. What happens if pacemakers fail? So, like, if one pacemaker fails, what goes? What's the logical progression within the heart? What is R on T phenomenon? SVT definition. Common complaints in acute coronary syndrome. Verification of medications. Right? What are your 6 rights? Why would you not give a patient a medication that is indicated? I'm not giving you that one. That one, if you don't know what happened to that one, what happens with PCI? What does that usually kind of indicate? Stimulation of the alpha and beta receptors. What does that do? Know the difference between inotropic, chronotropic, and dromotropic. How many big boxes, how many big boxes is in a 6-second strip? That's little boxes, Matt. There are 5 little boxes in a big box. How many big boxes are in a 6-second strip? Why does a first degree heart block have a long PR interval? Patients who will present with atypical signs and symptoms of an acute MI. Ripping pain. What is a ripping pain versus other pain? What are the other signs and symptoms that you may want to investigate in the event a patient's like, hey, I'm having some ripping pain. That covers 2 questions. If a patient is on a medication that ends in a lull, what kind of medication is it? Blood pressure! Just gonna shout words. What kind of... Oh, bože. Yes, antihypertension. Pero, which antihypertensive is it? If you have a blood pressure medication that ends in LOL, there you go. All right. Now, if you don't happen to know the como se dice, the brand name of medication, then you should be able to use context clues. All right, so when you're taking this test, I want you to be able to use context clues if you don't happen to know certain things, because if it gives you a 2 fill in the blank and you know for certain one of them, it doesn't matter what the first one is. Go with your gut that if you get that one right, you're good, because it's only one option, right? Can someone put the Zoom link up in the group chat for me, please? Maybe not Danielle, because she looks like she's driving. What is the difference between the Mobitz type 1 and a Mobitz type 2? oxygen therapy in a patient experiencing acute coronary syndrome? Yes. Yes, sir. Yep, I'll send it out when we're done. What do you do if you have a patient who's anxious and tachycardic? What is it? Oxygen for everybody. What does stimulation of the parasympathetic nervous system do? If you are anticipating vasoconstriction, which receptors are being stimulated? Okay, so this one, I'm actually going to kind of give you the answer because you guys didn't do IV therapy, really. So, if you're dealing with a patient who's in cardiac arrest, and you start an IV in the AC, the right AC, and you've got multiple attempts in the right AC, or in the right arm in general, there you go, switch. That's pretty much the answer, okay? Don't continue trying in the same arm, because that same arm, even if you do succeed, it's going to kind of leak everywhere. Because now you've punched it full of holes, okay? What does an S3 heart sound mean? There you go, boom. You already have, like, 2.5 points on this exam. Which coronary artery supplies blood to the right atrium, right ventricle, and left ventricle, and part of the left ventricle? Ventricle. Yes, it is. The RCA, not the rack. The RCA. Throw it back to like the RCA where they had little tiny dogs. Anyone remember that company? RCA company? Okay. I'm gonna stop talking now. All right. First line treatment for third degree heart block with hemodynamic compromise. Negative K. What is your treatment? What is your treatment for a patient who is in a tachycardia with a narrow complex with good blood pressure? This is another, like, really review your betas and your alpha receptors if you are in any way, shape, or form confused about them, because there's at least 4 questions about them. Yeah, alpha constricts, beta dilates. So A, B, C, D, alpha constricts, and beta dilates. Like leapfrog. 3-month-old infant with no pulse, no spontaneous respirations. Where is an appropriate site if you cannot get IV access? You're already past that. You're already up to IV. Thank you, I.O., Brianna. Oh, Lord. No, it's because he's on here as Bobby. Bobby D's iPhone. That's why. It's his alternative... It's his alternative personality. Stable angina versus unstable angina. Oh, I don't even know if this question is. Stand by. Another beta versus alpha medication wise though. Know which medications do beta 1 or beta 2. The downslope of the T wave, right? Know what all of your complex waves are, what they mean, right? So P wave is your atrial depolarization. The QRS is your ventricular depolarization. Your T wave is ventricular repolarization. But your T wave, right, you have that from the end of the QRS complex to the top of the T wave is your lost train of thought. Refractory. There you go. Is your is the first part of the refractory, then you the absolute refractory, then you have your relative refractory. Okay, so make sure that you have those. In case you're also wondering, when I get like quiet during lecture, this is usually the face I'm making as I'm trying to figure out what word I'm trying to find. Contiguous leads. What are they viewing? Electrical capture during transcutaneous pacing. What are you looking for on the EKG for that? JVD at a 45-degree angle. Left main coronary artery, what does that subdivide into? What is the length of time that your PR interval should be? So know your time frames for each of the complexes. Prolonged QT. Who would be at risk for a prolonged QT? What do you do after you administer a shock? There you go. Look, you're already up to 4 whole points on this exam. SA node. What does it do? There you go. What's its intrinsic firing rate? There you go. Preferred antidysrhythmic medication for a patient in refractory VFib. How much? Why is the electrical impulse delayed at the AV node? What happens when you get further away from the SA node? What happens to your conduction rate? We're just going to listen to Matt walk. Matt, you didn't get snacks for everybody? What is this bullshit? I don't think we have a choice but to let it happen. Oh, he muted himself. Fine, be that way. Runaway pacemaker. Use your magnet. Not the fridge magnets. They don't work. Yep. I hear the sound of Suffolk radios. Atrial kick. Which of your electrolytes maintain the depolarization phase? Si, senor. Which is what medications are calcium channel blockers. When you're looking at your graph paper, amplitude is what? And when measurement is, what do the boxes mean? Like ups and downs on the little boxes. Just, there you go. Amplitude is height, and what is going this way? Yes, but also like if you're like looking at the strip from like left to right as you're reading it. Time is horizontal. That's a great name for a time traveling book. Just in case anyone ever wants to start writing a novel. Time is horizontal. I'm gonna save that one. I need a pen. Yeah, Emilio. That was you, right? Alright. I'll cite you when I don't make a million. Yes, time is horizontal. Yes, sold. I'm making a note right now. No one, it's Corona time. Oh, Lord. There's a couple of patient scenario questions. There's at least 3 on this page alone. The first one has nothing really to do with cardiology. It's a pharmacology question, okay? So don't read too far into it, okay? This one is a kind of common sense one, right? If you have a patient who has ST elevations in lead V4R, which we talked about a lot today, and they're hypotensive, how are you going to treat them? Matt McPhillips is flashing us with french fries. This is not cool. You didn't bring snacks. You didn't bring snacks for everybody, though. Where are you working? Ugh. No, I'm gonna call for freaking snack delivery. This is the... Do you DoorDash? Exactly. Same color, it's all fine. Alright. Aspirin, right? Yeah, so you want maybe aspirin is a good thing to do. If you have a patient or you're trying to boost the blood pressure, what are you gonna do? It's another one. You have a patient who's in ROSC. Okay, what is your post-resuscitation care? Okay, if they don't need dopamine, right? Their blood pressure is solid. Maybe fluids. Repeat 12 leads. This one, hold on, I'm reading it and I'm not sure I like it anymore. Great. I'm here and I don't like this anymore. I'm just gonna give you this one. The ROSC question. The answer with PVC, if the patient has like PVCs, amiodarone. Keep that in the back of your head. What? We did this one already, right? Know the parts of what all the waves on your EKG mean. The amount of blood pumped out by either ventricle in a minute. Okay, what's it called? But what's it called? Nope. Not stroke volume. That's a single. Hey, ding, 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 winning. Another one, what is the different waves? Literally, you need to know what every single wave in your EKG complexes are, okay? You are going to have questions on every single one, right? What does the P wave mean? What does the QRS mean? Know them. Have them down, because you're going to always need to know them. BLS question. You have a patient in VTAC without a pulse. What do you do? There you go. PEA. That one. If you have a rhythm that is called a sinus anything, right? Sinus tachycardia, sinus rhythm, sinus bradycardia. Where is the impulse originating from? There you go. Enjoy your half a point. Plavix is a what kind of medication? There you go. Know what a Mobitz type 1, right? Remember your heart block type 1, type 2? Remember that they're also called the Mobitzes. So just keep that in mind, but know the difference between the type 1 and the type 2. So like if I say like, hey, this type, a type 2 looks like what, you can like kind of describe it and vice versa. What initiates depolarization? Okay, that's set up with your electrolytes, right? So what's that? The action potential is like that isoelectric line, right? Like that's where it's sort of hanging out. In order to depolarize, you need to have a movement of electrolytes. Which electrolytes moving? Sodium, calcium, potassium, right? What's the very first one that moves? Sodium. Sodium rushes in, okay? And then calcium is very slow moving. Yeah. Sodium potassium pump, right? So those two, right? Because potassium usually lives inside the cell. So as the sodium rushes in, it bumps the potassium out, and then the calcium's like, "Hey guys, what's going on over here?" and kind of like moseys on in. That's that's generally what's happening in your heart right now. Demand pacemaker. What does that do? Stable angina versus unstable angina. Medications that would be most effective for a patient who is hypotensive secondary to a vasodilation. Why do patients become unstable if their heart rates are really fast? Why is it not proper perfusion? Partially. Yeah, everything was good except for it's that the ventricles can't refill, which is why they can't push enough out, because there's nothing on the preload side to fight afterload. But yes. How do you treat sinus tachycardia? What wall of the heart is supplied blood by the circumflex? If you don't treat an ST elevation MI, what is the end result on the EKG? No, like the ones who muscle through and they're okay. Which ones? Yes. The pathological cues. Another patient assessment one, if you have a patient who's telling you that they have a breathing problem with an inhaler and also take a heart pill, what issues would you expect that they have? Which is usually caused by... Yes. Stick with the first one. Don't go any further. Again, sympathetic nervous system versus parasympathetic nervous system. Know the parts of your complexes, right? J points are important also. What do you do if you have artifact in your EKG tracing? Generally stop shaking your patient is probably the first thing to do. If you have a patient who has ischemia in the anterior wall, remember the difference though, okay? There's 3 different levels of I issues. So they all start with the letter I. Ischemia is T-wave inversions, okay, or depressions. Injury is that ST elevation. Infarct are Q waves, okay? People were having a hard time with this last year for some reason. It's stages, okay? It gets progressively worse. So the first one is like, oh, I'm a little depressed. Then it's like, yo, seriously, pay attention to me. Then it's like, well, fuck off. Literally, in the UK, this means fuck off. This is a Q wave. This is okay. This is... Yes. Yes. No problem. Yes. So, all right. So it's in the I think the first, no, it's in the 12 lead lecture. So injury, you get the ST depression, okay, or inverted T waves. The problem with injury is it also tends to potentially look like reciprocal changes. So if you do have an EKG that has ST elevations, you will see depressions elsewhere. If you don't have any elevations, you just have depressions, you can either A, go hunting for them, because it might be in a right side EKG or a posterior EKG, or it's just injury. So you'll see a patient who's dealing with, ischemia. A patient who has ischemia is your stable angina patients, or yes, T-wave inversion. So the patient's like, I'm having some chest pain, and they're like, okay, sit down. It starts to get better. They'll probably have T-wave inversions or slight depressions. What we're looking for, no more than 30 minutes, exactly. So once you get past that 30-minute point and they start to have elevations, that's when we start to call it an injury, okay? Because now it's progressed past, like, I need a little oxygen to, I'm screaming in pain, this is not good. The Q waves is when you have these really deep, so you have like the P wave, and then you have this really deep Q wave right before the regular QRS complex. It's larger than one small box and deeper than one small box. I forgot the actual fraction, but it's significant size of the actual QRS. And that's what happens when that area actually does die, and it's not reperfused at any point. So that's where that kind of trajectory goes. It won't be elevated. It'll just be like the normal complex, and then you'll have like a big deep Q before it goes into the yeah. Yeah, no, and unfortunately, that's kind of how it gets boiled down after a while. It's all everyone starts to use it interchangeably, unfortunately. But when you're sort of teaching people in the first place, you need to have that clear delineation. No problem. What happens if you don't treat VTAC? Right side of the heart versus left side of the heart. Joni, what were you saying? Yes, it does. Yep. Good. If in a healthy heart, the right side versus the left side, what's the difference? Where it's going, and how the level of pressure, right? Because you have your high pressure versus low pressure pump. What is your treatment for a patient with significantly compromised cardiac output and bradycardia? I know now. All right, so here, we didn't do this in lecture, because usually it gets covered in skills labs, so I'm going to do it now. And feel free to put this in the group, because there's going to be people who are probably not going to necessarily have time to do the video. It's medicine versus Edison. When you have a patient who is no longer stable, right? They are hypotensive, they are AMS, something like that. You're going to go right to an electrical therapy. So if you have a patient who is severely bradycardic and they're super hypotensive, you're going to go right to transcutaneous pacing. You have a patient who's in SVT and they're hypotensive, AMS, right? Whatever. You're going to go right to synchronized cardioversion. Kind of think of it like, if you're in cardiac arrest, I'm going to defibrillate you. If you're going your way towards cardiac arrest, we're going right for the electric. You have a patient who's in SVT with a blood pressure of 120 over 80, they can have some adenosine, right? You have a bradycardic patient who's like 100 over 60, they'll get the adenosine. Or atropine, sorry. So that's we didn't do that in lecture. So there's your clear delineation between the two. Yes. 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 Generally, yes. I mean, you can have a patient who is. There are other ways, like if they're altered mental, right? So if you have a decent blood pressure, but they're completely altered, you're ruling out the idea that they're like hypoxic secondary to the bradycardia. That makes sense. Um, what causes myocardial ischemia? Um, fibrinol- fibrinolytic medications. I mean, you can answer if you want. Go ahead. Yes, hypoxia. That is the answer. But what's causing the hypoxia? In the heart, Joni. Yeah. Usually a blockage, right? Don't go wandering around, blocking the way. Uh, common causes of bradycardia. Not normal bradycardia. What? Disregarding. Mm-hmm. Yeah. Yeah, I think that's maybe Wednesday you could schedule it so that everybody will be there, but I think that's a great plan. Uh, I don't know. I honestly don't know what the social distancing rules are for that. But if you find a nice park, no, no calipers. Yeah, the following one. Yeah, there's no actual rhythm strips on this exam. 200. I'm uncertain of the time. I think it's 2.5 hours. You're welcome. Uh, be there. Um, if you have a dialysis patient who doesn't feel well and they've missed some treatments, number one electrolyte imbalance that they're going to be dealing with. Potassium. Beautiful. All right. Cardiac output. What influences cardiac output? What does a delta wave signify or look like? Um, patients who have a right ventricular infarct will present with what classic symptom? Leads V1 through V3 give you what view? Yes. What is the duration of a QRS complex? What idioventricular rhythms? Generally, broad statement about idioventricular rhythms. AFib, how do you interpret that? What does it look like? A regular cardiac rhythm at the rate of 104 beats a minute, upright P waves, a PR interval of 0.14 seconds, a QS and QRS complexes that measure 0.1 second should be interpreted as what rhythm? They like to throw that on the state too, which is why I read this one out for you. Yes, which is why it's super important for you to know how long each segment is supposed to be. I do believe that you'll have scrap paper, so if you would like to do an info dump before you start taking the exam, That is advised. Yes, the PR interval should be no more than 0.2. 0.2, one big box, right? So if it's bigger than one box, so five small, right? So five small boxes is one large box, one that's 0.2 seconds. So if it's greater than 0.2 seconds, it's a first degree heart block. Yes. Yes. Regular cardiac rhythm with a rate of 104 beats a minute, upright P waves, PR interval of 0.14 seconds, and QRS complexes that measure 0.1 second should be interpreted as, excuse me. There you go, as I get you all to yawn. Differences between, yes. Differences between pericardial tamponade and tension pneumo. Drugs that have a positive chronotropic event will do what? What's up, Joe Nico? Yes. Yes. Good. So remember, make sure you're very clear. Inotropic, dromotropic, chronotropic. Go ahead. Yep. Speed of conduction. Dromo, think of Dromo as sleepy. Like that's the god of sleep. So if you institute more Dromo, it's slower, it's sleepy. It doesn't move through the conduction pathway as quickly. Clinical findings least suggestive of left-sided heart failure. What would you do for a patient who has a blood pressure? Bro. The dog is stretching all the way across the bed. Has a blood pressure of 96/68, a rapid radial pulse at 200 beats a minute, and he is profusely diaphoretic. How would you treat him? How are we going to slow that rate? Medicine Edison! There you go! There you go! Remember, you can zap people now! Yep, no problem. Alright, an electrical wave moving in the direction of a positive electrode will cause what kind of deflection on the EKG? Mother... Yes. Perfect. Yes. What causes syncope in the context of cardiac compromise? What are the layers of the wall of the heart, starting with the outside, working your way in? What would you expect in a patient who's experiencing a right ventricular infarct? There's at least 2, maybe 3 questions on right ventricular infarcts. What happens? What's your common clinical finding? And which artery is involved? So those are things you should probably know. Situation where you would likely not be able to palpate a pulse despite effective chest compressions. The fibers that are distributed throughout the ventricles. Know your electrical conduction pathway names. What's going on during the refractory period? Collateral circulation. Paroxysmal nocturnal dyspnea. Whoa, what does it do? Like, what is this? It's basically literally what's the definition of paroxysmal nocturnal dyspnea? Wakes you up at night. Perfect, because you can't sleep or can't breathe or sleep. Cardiac arrhythmias are most importantly evaluated in the context of what? Perfect. I think, did you just read this straight from the textbook? Are you sure? What does, literally, the definition of Wolff Parkinson White? Um, pulsus alternans. We talked about it today. Um, that's the same as the other one. Patient condition is important. When you're administering a vasopressor, make sure that you carefully titrate and monitor your patient. Which lead is the QR or PQRST configuration upside down? No. Yes. Perfect. The one we never talk about, AVR. The only one that is upside down. Yep. AVF is for axis deviation. 100% correct. That one you should be able to get without issue. As another description of a EKG, which I'm not going to read you. You have to get that one on your own. Coarse VFib versus fine VFib. Don't hit it! Don't hit it! Drugs that cause an increase in heart rate. Risks associated with fibrinolytic therapy are artificial ventricular pacemakers. What do they look like on an EKG? Most common cause of cardiac arrest in adults. Sort of. Frank Starling's principle. Know that one. Sort of. It's the further you stretch the heart, the more the heart will pump out. Theory. Until it reaches, yeah. Yes. You have a patient whose heart rate is under 150 beats per minute. Will you give them adenosine? Process how aortic dissection begins. Basic patient assessment. You give a medication. What do you do? The EKG only provides you information about what? What part of the heart? Thank you. Does it tell you anything about how well the muscle is working? There you go. All right. After you get an advanced airway, what does your breath rate switch to in cardiac arrest? Throwback to the airway section. Ventilations are delivered at a rate of 8 to 10 breaths a minute. So what happens with when you get an advanced airway, you don't have to stop compressions. So compressions can be continuous. So you're pumping throughout. So you're breathing like almost normal. Eight to 10 breaths a minute. 8 to 10 breaths a minute. There's 2 questions on that one. How long is a prolonged PR interval? And what causes it? What is a wandering atrial pacemaker? What does a prolonged QT indicate? Q waves are considered abnormal or pathologic when? Here's that fraction. It's 1/3. What causes dizziness in a patient you're suspecting is also experiencing an MI? Left-sided heart failure versus asthma. Who will win in the ring? Decreased cardiac output versus SVT. Why? Most effective drug for treatment of non-vagal induced bradycardia. Hint. It's not actually. Not. It's friend. There you go. All right. Effect inotropy, chronotropy, dronotropy. How many beats of VTAC do you need for it to be a run of VTAC? Holla. Patient care. You have a 29-year-old male with a heartbeat of 46. It's okay, but yes. Thank you, Brianna. What is automaticity? What do you do after you give a... What is automaticity? You have a patient who is got a heartbeat of 46 at the gym, 29 years old, complaining of some nausea. What would you do? No. He did not. He did not. What other things do we have in our box that can fix that nausea? On Dancitron. Yeah, you go. Yeah, you should at least have, at the very least, have them on a 3 lead. But yes, if you have a patient who, and this is where this question kind of like doesn't do, its choices don't necessarily do it justice. It doesn't give you like the do a 3, do a 12 option. But if you have, a patient who's experiencing nausea, vomiting, whatever, it's great practice to do a 3 and do a 12, because especially if you're going to give like Zofran can and will potentially prolong the QT, and then you have other issues on top of it. A little bit. So we're kind of building off of like the last module a little bit, because we did do a lot of pharmacology and being familiar with drugs and what we can do with them. So we're building off of that a little bit, but trying to focus it on cardiology. Yep. What medications are in your cardiac arrest protocol for VFib? forget to resume CPR as your defibrillator is charging. If the AV node is bombarded by multiple impulses, no. If the cells are already, remember we talked about this is the process that causes AFib. And it's being bombarded and bombarded and bombarded, and it can't like filter everything out, so it sends them back around. It's called re-entry. Yep, re-entry. Nah, yeah, it is, but not for this question because that's gonna screw you up and picking the right choice. Yep, re-entry. What rhythm can never be classified as pulseless electrical activity? There's two. That's technically nothing. No. That one could be PEA. Yep, VTAC and VFib, because they have their own names. That's literally the only reason. They have their own names, so they can't be PE. Leads that show you the best view of the anterolateral wall. What does V3 and V4 look at? Monomorphic VTAC. What is it characterized by? What is spironolactone? Spironolactone? What? It is a diuretic. There you go. Literally, that's the whole question. Stuff? I think so. It's very popular. Really? Like topically? Huh. That sounds like a terrible plan. Yeah, seriously. Oh, Mike Mancino's going to a job. Hold on, everybody. Let's watch him. He's responding. I see like flashing lights out of the corner of my eye real quick. Drive safely! It's okay, drive safely. No HIPAA violations. So close so far. So close. If you have a patient who is hypotensive while in a supine position, are you going to sit them up? Thank you. Please, baby Jesus, don't sit up patients who are supine and hypotensive. I had one partner who was obsessed with this. I was like, you need to stop. What is aberrant conduction? Oh, okay. This one's a careful reading question. You have a patient who's got chest discomfort and nausea. Medications, Synthroid, Lipitor, Cialis, and one baby aspirin. What medication were you least likely to administer? With a blood pressure of 112/70. Definitely don't give him more Cialis. Yes. There you go. Please don't give him more Cialis. He's excited enough as it is. You look like your evening could be improved somehow. Oh, Lord Almighty. Precordial leads do not view what part of the heart? Acute coronary syndrome is the term used to describe what exactly? Epinephrine is used to treat patients in anaphylaxis. Why? What is it? What is the purpose of epinephrine in treating anaphylaxis? Um, what does a third degree block look like on an EKG strip? If you had to describe it. Um, what makes it? Go ahead. Okay, good. Um, is there a PR interval? There you go. What makes it difficult to distinguish VTAC from SVT? What situation? Uh, bundle branch block. We're going for that one. Um, which where's the mitral valve? Right, what does that do? Is it on the left side, right side, high pressure, low pressure? What EKG abnormality is most consistent with hyperkalemia? We talked about this briefly back in our 3 leads. It's a very... Go ahead. No, hyperkalemia. By T waves. Very pointy T waves. MI. How would you diagnose an MI? Elevated ST? Yep. Mm-hmm. Mm-hmm. And there you go. And that's your answer. Parasympathetic versus sympathetic again. SA node, what does it do? You have a young patient in SVT that spontaneously converts to a sinus rhythm, and you see a rapid upslope into the R wave. Left heart failure, pulmonary edema. What do you do? PAC, PVC, PJC. Really just PAC and PVC. What is torsade de poids? What? Polymorphic. What does S1 part sound mean? Lub. What is making the lub noise? What valves are closing? Yes, tricuspid and mitral. And the lub is mitral and tricuspid. The dub is the aortic and pulmonic. Keep those two straight. And if an MI damages the conduction system, what do you usually see other than bundle branch blocks? You're going to have a fast heart rate or a slow heart rate? If you jacked up the conduction system? It's a slow heart rate. There you go. Difference between idioventricular and an agonal rhythm. Immediate treatment for a patient who's experiencing an acute MI. Where would you see an inferior wall infarct? Thank you. Profound. Time is horizontal. I think that's going to be your theme for this class, actually, because every class usually has like a little logo. like 2 classes ago, it was do no harm, no harm. Or, spelling no, do no harm. I'm not explaining this well. I have hit sleepy. Um, Beta blockers. Know your beta blockers. Beep. Biphasic defibrillator settings should be where. Lead 1 versus lead AVF. What parts of the heart do they look at? What is a systemic complication of IV therapy? Systemic. Thrombosis or emboli. How about that? Yeah! Somewhere's, yeah, it's real rowdy somewhere. Oh, goodness. What happens to the AV node during a 3rd-degree heart block? What happens if you give a patient morphine and they become less responsive? What does a J wave mean? Wide QRS preceded by a normal P wave. What does that mean? What is the brief pause between the P wave and the QRS mean? Where does V1 go in terms of the sticky? What makes chest pain, cardiac-related chest pain, better or frequently? What is the appropriate dose for epi in a cardiac arrest? Where do the positive and negative leads go in the limb leads in Einthoven's triangle? Just remember, the legs are always positive. Look it up. We're at that point. I've given you like 80% of this test. You can go look that up in the textbook. Complications associated with AFib. Yes. If you have a child in cardiac arrest, where are you going to get IV access? Nope, that was IO. IO. That's all you need. Yeah, it's just phrasing and careful reading. So if you get one of them wrong, you're screwed. Or you're really lucky because it's being phrased in a different way. Maybe you'll get it right the next time around. What causes VFib? Why? I definitely didn't choose this question. Your order to give the patient epinephrine, patient in cardiac arrest, epinephrine via the endotracheal tube. Why is this acceptable? Large surface areas available in the respiratory tract. I didn't choose this question, so I'm going to give it to you. Enjoy your half a point. What do you need to make sure that the patient can do if you're going to give them aspirin? Yes. What is tadalafil? Can you give nitro to those patients? There you go. What defines a hypertensive emergency? ST segment. Where should that live? You have a patient of the heart rate of 72/50. Sorry, a blood pressure of 72/50 and a heart rate of 38. Good. Hold on, wait. The dog is down. He's down. He's out cold. Like every time. Yeah. Yes. Yes, thank you. At least someone's paying attention. Yeah, Rob, you better sit next to Joe during this test. Oh my god. What's the Levine sign? There you go. Left-sided heart failure. Common signs of left-sided heart failure, except for what? That. I'm just going to continually mute you. Asystole. What is that? Usually a end result of. And last but not least, CPR. Allow for push hard, push fast. Allow for adequate recoil. There's a bunch of CPR questions on here. Okay, y'all should get them right. They're BLS. If you can't CPR, and I gave you the other one. I gave you the new advanced airway info. Sex pins. Awesome. I think a list does exist. We're cutting you off. All right. I'm